My name is Michael, as Evro said. I've been invited initially to speak on neuroendocrine tumor from a surgeon's perspective, as my consultant Adam Bartlett was meant to be away today, but obviously with level 4, we're all stuck where we are. And unfortunately, I can't see all you guys face to face, but hopefully you guys enjoy this talk. So as Evro said, I'm currently the HPB surgical fellow at Auckland Hospital, and I'll be there till February, and I'll be moving on to Westmead in West Sydney for a year next year. So to start with, I've got a 57-year-old male, normally well. He was diagnosed with maybe MS 6 months prior by the GP. There have been no neurology or MRI involved in this diagnosis. He presented to ED with transient global amnesia. So his recollection was he went to bed Saturday night and woke up Monday morning. He had no recollection of Sunday. And he does not drink alcohol, by the way, so it's not really a hangover. And when the ambulance actually found him, his blood sugar was 2. So he's given dextrose by the ambulance and his symptoms completely resolved. So ED did examination, blood, CT hit, and it was completely normal, and he was discharged home the same day. He subsequently presented the next day back to ED. He had another bout of confusion, which resolved spontaneously. And this time around, when they checked his blood sugar, it was 9. And he was admitted under the medical team, and he reported recent stress and anxiety over work, and he was not eating very well. But interestingly, he says after he eats, all the symptoms actually go away, which probably I can relate very well. If I'm hungry and operating a long time, I probably won't feel very well either. And there were concerns raised by the medical team about whether this was just purely him not eating very well or in an insulinoma. So they did a pre-breakfast blood sugar, which was 1.7. Which, as most of you would know, that probably most patients will be comatose with that blood sugar, but he was awake but just a bit unwell. C-peptide, which is a marker of insulin secretion or endogenous insulin secretion, is quite high. So there are suspicions that he has got an insulin secreting lesion. And as normal, we would do tumor markers to make sure there's no other malignancy. And the tumor markers that we do would be CA, CA125, and CA99, and they were all negative. He's not diabetic, but obviously we're also worried whether this is iatrogenic or drug-related. So we did a sulfonylurea drug screen, and that was negative. Now on to the radiology. So the first scan on the top is an MRI scan, and the bottom is a CT scan. So this is an axial scan of an MRI, and it shows a 5-centimeter lesion at the body of the pancreas, and there's 2 further liver lesions that are not fully characterized. And with regards to the CT, again, shows a solitary lesion and multiple enhancing lesion in the liver. And you can see the splenic artery draping over the lesion in the pancreas. So he was transferred to our care with close monitoring by endocrinology. So he was started on dioxazide twice a day and increasing the dose. It's a insulin secreting suppressor, and to monitor his blood sugar, and also started on octreotide for a longer acting effect. He was finally discharged with this plan that he would test his blood sugar 4 times a day, waking before bed at 2 in the morning, until his blood sugar is stable for a few nights, just to make sure that the medication is working and he's not getting a hypoglycemic overnight or when he becomes unwell. So we got a Gette PET CT, and again, it shows the lesion in the pancreas lighting up and a few liver lesions in both lobes of the liver, but they are quite small. So Gette PET is just an octreotide labeled test, and it just lights up all the neuroendocrine tumor that we can see. So he went ahead for surgery, and I won't go into too much details of what we did, but He ended up having a distal pancreatectomy and splenectomy, mainly to get a clear margin, and the splenic vessels was closely associated with the lesion. There are 6 liver lesions. I've only shown you a couple there, and they're treated with a combination of resection and also ablation. He actually recovered really well. All his medications were stopped, and he was discharged on day 6. And for those that know that we have to give vaccinations post-splenectomy, he was actually given the vaccinations prior to his last discharge in preparation for surgery. And if you're worried that patients will not be getting vaccinations prior to surgery, we always do it the day before discharge. So you can also do that if you're worried about compliance of patients getting vaccinations prior to surgery. It also saves them the hassle of going multiple times to the GP to get vaccinations. So with regards to histology, he actually has a 45mm lesion, clear margins, and no lymph nodes involved. It's a very slow, I understand you probably heard about grading of neuroendocrine tumor. So it's actually a very low Ki67 in the pancreas, and in the liver lesions that we took out, there were 3 small ones, and all of them had low Ki67. So in summary, he has a grade 1 well-differentiated neuroendocrine tumor. It is metastatic, which is unfortunate for himself. And post-op, the NET MDM recommended to have a baseline MRI liver 3 months post-operatively, just to make sure there's no other lesions that we have missed. And then the neuroendocrine MDM will discuss what follow-up surveillance he will have. In the future, octreotide can be considered to suppress any of these lesions for a while. Just a brief overview of what neuroendocrine tumor is. It's actually a malignant cells of the neurocrest origin. The most common cause that we see is around the GI tract and the pancreas, which is the majority of them. And the small intestine is the most common site of neuroendocrine tumor, and followed by the appendix, rectum, and colon. And the lung, respiratory site, is the second most common, and other sites are the minority. They are variably malignant, obviously between grade 1 to 3, and neuroendocrine carcinoma as well. And they're graded based on differentiation and mitotic rate and Ki67. Patients can present with signs and symptoms that are variable and vague, and most of the patients are very vague. And it depends on where the location of the tumor is and how big it is, and whether they have any metastases from this tumor. And patients can range from no symptom to what we call carcinoid syndrome. And carcinoid syndrome presents normally with flushing, bronchospasm, and diarrhea, which are the most common. And it's associated with right-sided heart failure. And because the liver breaks down any of the serotonin or the biomarkers by the tumor in the GI tract, they normally require a lot of liver disease or liver metastases or distant disease that are outside the GI tract, because the liver will break down all these serotonin. And the same with the lung. If you have it also breaks down some of the serotonin as well. So I'm just going through what we see in general surgery or HPB surgery in terms of different sites of tumor. The appendix is generally incidental post-appendicectomy. This is what the NET MDM most commonly see is patients coming with appendicitis or vague right iliac fossa pain. We take them to theater and we take the appendix out and found there's an appendiceal neuroendocrine tumor. It does generate a lot of work, and the management of this depends on the size, the margin, and whether the mesoappendix have been taken with the appendix. Because most of the time, if the mesoappendix is not taken because of the acute inflammation and the tumor is a big one, there is sometimes a requirement to have a completion right hemicolectomy. But these are always discussed at the NET MDM. Small bowel NET, they present with most commonly periodic abdominal pain. And obviously this is very vague. The most common cause that neuroendocrine tumor can cause small bowel issue is either an obstruction from the lesion itself outside the lumen or intraluminal, or what we see more commonly as well now is that the tumor itself scars down the mesentery of the small bowel, what we call cicatrizing lesion. And you can see it on the scan that all the mesentery is drawn around the neuroendocrine tumor. And this causes vascular congestion, either from most likely a venous issue, because if you have an arterial congestion or obstruction, the gut would die. But most patients with small bowel neuroendocrine tumor has venous congestion and symptoms of that. And we do take a lot of small bowel lesion away because of long-term symptoms. Stomach NET is rare, but it can be associated with gastritis. So chronic gastritis can lead to neuroendocrine tumor of the stomach. Again, colorectal NET is very rare, but they are found to be more aggressive than standard adenocarcinomas. Obviously, being an HPB fellow, I'm more interested in the pancreas, and it depends on where the tumor is and whether it's functional and non-functional. So non-functional is most commonly found incidentally, and the functional lesions are less common than non-functional. And obviously there are 6 different types, and I won't go through them. And this patient has an insulinoma, which is most likely a benign one most of the time. And gastrinoma is more malignant and can be found in a separate location. And when the patient presents, I know you guys have heard about triple assessment for breast, but generally we do triple assessment for all malignancies anyway. First one is clinically, history and examination. Most of the time it's not very satisfying because there are no symptoms and nothing much to find on examination. And then biochemically, we test serum chromogranin A and urinary 5-HAA, which is a breakdown of chromogranin A. And if we're suspicious of pancreatic functional lesion, we do extra tests as the previous table. And most of these would actually be driven by the endocrinologist. So we normally see them after the endocrinologists have worked them up for us. And radiologically, in endoscopy is the next step, and the CT is most commonly used. But for the pancreas and the liver itself, we normally do an MRI as well. And if we find either disease or staging for disease, we do get a PET CT and sometimes an FDG PET as well. And this needs to be approved by the NetMDM. And I'm in the process of auditing whether we need to get a PET CT for all solitary pancreatic lesion. Management of patients that come up. It is truly a multidisciplinary approach to a NET. So mostly medical oncology combined with surgical oncology, which is surgery. And obviously we involved the other specialties in the blue circle, endocrinology, pathology and radiology, and nuclear medicine for get a PET. And the radiation oncology, sometimes we do involve them for ablation or radiotherapy. And all NET patients are discussed at the MDT, the National NET MDT, which is quite a well set up MDT. As surgeons, we decide where they are, how big they are, and whether there are any distant metastases. Most cancers we deal with, if there are distant metastases, we tend not to operate. But for NET, if they are causing a lot of symptoms, especially the small bowel mesenteric NET, we do debulking surgery. It is a form of palliation, and even in presence of metastatic disease, we do resect the mesentery and the small bowel, because if it's a grade 1, the tumor would be there for a long time, and the patients would have chronic abdominal pain for years. And so we do debulk the lymph node disease and take out a little bit of small bowel, if possible. It's obviously leave as much as possible, so the patients can have relief from symptoms, small bowel obstruction symptoms for a long time. And also facilitates systemic treatment in the future, because if the bulk of the disease is not removed, then the systemic treatment is actually focused on the primary and not on the distant disease. And an aesthetic team and the surgical team have to be aware of carcinoid crises, where when we on induction and also on during the operation, where they drop their blood pressure and go into bronchospasms. And this is just the secretion of the active serotonin while we operate. So basically, if you touch the tumor, it might secrete a lot of serotonin into the system, and give them a carcinoid crisis on the table. And radiologically, you can ablate the liver lesion like we've done for our patient, also sometimes percutaneously, just for local control. And if there's a lot of disease, you can do embolization where you embolize the artery to the lesion itself, because it is an arterial enhancing lesion, whereas colorectal metastatic disease is mostly portovenous disease. Or you can squirt chemotherapy down the artery into the lesion itself. And now we're doing more selective internal radiation therapy, where the interventional radiologists put beads into the tumor itself via IR. And the mainstay of treatment is still, a lot of it is systemic treatment, where we give octreotide to suppress obviously the somatostatin receptor, and also chemotherapy and palliative care. And as all of you have heard in the news and in the education day so far, is polypeptide radioactive radiotherapy has been approved in New Zealand, so patients do not have to go to Australia or Melbourne to receive this. And it's only about 6 weeks ago that it's been announced. And obviously during COVID, patients are finding it quite hard to travel to Melbourne to get the treatment they require. So it's actually great news that we're getting it here locally. And in conclusion, a neuroendocrine tumor can present in many ways, and most of it is incidental because we do scan patients a lot when they come in with abdominal pain or other presenting complaints. And because the imaging is so good and we're so good at scanning patients, that we are finding a lot of neuroendocrine tumor that we would not have found in the past. So it does generate a lot more work for the NET MDM. Treatment is multidisciplinary, and if possible, the main aim is still resect all disease that are visible. And even if you can't resect all the disease, if you resect most of the bulk of the disease, then you can provide patients with symptom relief or even palliation. And especially if grade 1, they might have years of symptom relief before the tumor comes back. And if the local DHB is unsure whether the disease is resectable, especially with these large small bowel mesentery mass, they always discuss at the NET MDM, and the surgeons around the country can have a discussion about whether they're resectable or not. And the NET MDM obviously plan the treatment, but importantly also give the local DHB an option or options of what to do with these patients, because they are quite hard to manage. And if you have a consensus or brainstorm between different specialties and specialists, I think it gives the patient a bit more empowerment, which is very important. And also the NET MDM would give a surveillance plan in terms of how often we have to scan these patients, whether it's every year, every 2 years, or 6 monthly for beginning for high-grade disease. And you have to have NET MDM to have approval of the GET-8 scan. And obviously, if in doubt, you can always call up your friendly neighborhood surgeon. It depends on your neighborhood surgeon, I suppose, but most of the time we are friendly, and most of the time we are very helpful. Any questions?
Michael,